Welcome everyone to another Supporting Client Health and Wellness class. We are so excited to have all of you here today with us. As most of you know, my name is Nellie Camarena. I'm one of the nurses from the Far Northern Regional Center out of the Chico office. It is my pleasure to introduce Lisa Graziano, a Prader-Willi syndrome specialist who provides training and consultative services on various issues related to PWS. She presents at conferences throughout the country on such topics as behavior management, educational supports, residential and vocational supports, conservatorship, HCBS issues, and a whole array of topics. So we are so excited to have her here with us. I will pass on and let her do any additional introduction and let her continue with her presentation because she has a lot of good info to share with all of you today. So again, thank you, Lisa, for joining us, and I will hand it over to you.
Thank you so very much. I'm excited to be here with y'all, and all those things that were mentioned, those are all related to Prader-Willi syndrome. So in the interest of time, normally we break out, we have room for questions in between different sections, but in the interest of time, I'm going to ask you to note your questions, send them off in the chat, and then at the end of the presentation with whatever time we have left, and I'll be here for as long as y'all want, we'll answer those questions for you. So today's going to be an overview of Prader-Willi syndrome. So, I know there's a lot of different kinds of people here. So I just wanted to kind of prompt you with what you in your particular field or specialty need to know about Prader-Willi syndrome. So if you're a regional center professional, you're going to need to know symptom development throughout the lifespan, symptom management throughout the lifespan, the supports and services needed in various settings throughout the lifespan. You're going to need to know the ICD code for Prader-Willi syndrome so you can properly put that in the CEDAR. You're going to need to know how to accurately assess the symptoms for a really good evaluation element. If you're a residential professional, you're going to need to know the common symptoms in adulthood. You're going to need to know the Prader-Willi syndrome environmental basics. You're going to need to know nutritional and activity needs. You're going to need to know PWS behavior management strategies. And also for your vocational, day program, volunteer, recreational provider professionals out there, you're also going to need to know the common symptoms at various ages, PWS environmental basics, and PWS behavior management strategies. And if you're a medical or a therapist professional, you're going to need to know symptom development and management throughout the lifetime. And you'll need to know you're going to be needed as an advocate for your patient for supports and services throughout the school setting, home setting, work settings, like IHSS paperwork and things of that nature. Prader-Willi California Foundation will provide you with and your staff with the information that you need in order to support your consumers, patients, clients who have Prader-Willi syndrome and their families and the professionals on the multidisciplinary care team that is required when we have a diagnosis of Prader-Willi syndrome. So what is Prader-Willi syndrome? Well, the pronunciation is Prader, that it's named after four Swiss physicians who saw this as a syndrome. So Prader-Willi syndrome is a rare, non-inherited, genetically based medical disorder. It occurs in about 1 in 20,000 live births. It affects all races and both sexes equally throughout the world. There is no known cause for most types of PWS. It occurs spontaneously at conception most of the time. And PWS is the most common cause for a genetic cause for morbid obesity and premature death if it's not properly managed. Symptoms occur due to genes that are missing on chromosome 15, and those genes regulate every single system in the body, including growth, muscle tone, breathing, sleep cycles, temperature regulation, cognition and learning, sexual development, stomach and bowel emptying, metabolism, emotional regulation, behavior management, and the hallmark symptom of Prader-Willi syndrome, hunger and satiety. Every single system in the body is affected by Prader-Willi syndrome. Without appropriate support, people with Prader-Willi syndrome will die prematurely. At about the average age of in the mid-20s, maybe late 20s, from choking, poisoning, gastric rupture or necrosis, intestinal rupture or necrosis, impulsive, dangerous behavior, complications of morbid obesity, complications related to abnormal neurophysiology. But with appropriate interventions and supports, quality of life and the lifespan are significantly improved for the individual as well as for everybody else who's in that individual's life. So let's take a quick look at the physiological symptoms of Prader-Willi syndrome. So PWS is a multi-stage disorder. The first stage is a failure to thrive, and that is there's zero interest, desire, or ability to feed. This we'll look at when this happens in a second. The second stage is hyperphagia, and that's an insatiable drive to eat or obtain food despite the quantity of food consumed or the timing of food consumption. Each of these two stages, failure to thrive and hyperphagia, is distinctly different from the other and presents its own unique and challenging set of symptoms. And each stage has phases and subphases that are distinctly different and present their own unique challenges and set of symptoms. So failure to thrive actually occurs in utero, but we usually talk about it after the infant is born. So it's from birth to about 1.5 years old. And these symptoms include severe hypotonia, weak muscle tone, that interferes with the ability to feed. As one component of inability to feed. Underdeveloped genitals, respiratory problems, delayed developmental milestones, and feeding problems that are caused by extreme fatigue, severe muscle tone weakness, apparent lack of appetite, impaired motor coordination, a faulty epiglottis, and gastroesophageal reflux disorder, GERD, in some cases. Infants require specialized support from feeding, ranging from special nipples, positioning tricks that other parents can share, and NG tube feeding. G-tube surgery is frequently required, quote unquote, by a lot of NICUs before they'll discharge the infant. So they don't want to do NG tube for long. But this is a very invasive surgery, and it can very well be avoided with appropriate intervention, and PWCF can help you and the consumer that you're working with or patient you're working with to identify how can we avoid a G-tube. There are 3 main nutritional phases in Prader-Willi syndrome that you kind of need to know. Again, that phase 1 is that hypotonia. Phase 2 is that weight gain that you probably don't know about. Weight gain without any increase in calories. So this is pretty, it's built into the physiology of people with the syndrome. So without any increase in calories, children with Prader-Willi syndrome will gain weight. And then phase 3 is characterized by hyperphagia. So in phase 1, we've got no interest in eating. And then all the way to phase 3, we've got an extraordinary amount of attention, focus, everything for many revolving around food. When I say for many, the degrees of hyperphagia will be different from person to person, but everybody with Prader-Willi syndrome eventually will reach hyperphagia to some degree. What is hyperphagia? Well, it generally starts around 2 to 3 years of age, where it is medically, it's that dysfunctional appetite regulating system. It is a never-ending physiological neurochemical drive to eat or obtain food that lasts throughout the lifetime. It includes a preoccupation with food, food seeking, foraging for food, manipulating to get food, sneaking around to get food, hiding food, hoarding food, eating unusual food items like sticks of butter, insides of frozen ice packs, pet food, mouthwash, rotten food taken from the trash, taken from the ground, gum that's put under desks. All of these are food sources. In addition, even skin, tissue, blood, excrement, nose particles are all considered food sources for people with the extreme sides of hyperphagia and Prader-Willi syndrome. Hyperphagia causes food-related anxiety that frequently results in dangerous behaviors, including verbal aggression, physical aggression, elopement, running away, burglary, theft, self-injury, impulsivity, and lack of regard for personal safety. Some examples of this, well, what do you mean impulsivity, lack of regard for personal safety? We have individuals who may jump out of a moving car because they're upset, or AWOL up the side of an on-ramp in order to look for food, get food, etc. So in hyperphagia, the brain functions as if there's no food around and the body is starving. So the brain drives the individual to eat as much food or find as much food and hide it away as possible. The brain does not register feelings of satiety in any normal way, despite the quantity of food consumed or when the last meal was consumed. The brain tells the body to store the food it does eat as fat in the body, very differently than the norm. And the brain lowers the metabolic rate to about half what it should be in order to hold on to that food as an energy source for when there's no food next, right? So unmanaged hyperphagia, plus that very slow metabolic rate, will cause rapid weight gain and the potential for premature death, and causes maladaptive behaviors. Death can occur from even a single overeating episode. Individuals who have always been thin are at greater risk for death from even a single food overeating episode. So that Prader-Willi syndrome hyperphagia is a lifelong, life-limiting, and life-threatening symptom, and it severely interferes with the quality of life for the individual who's diagnosed with Prader-Willi syndrome, as well as all persons who live with that individual. And we often see it interfering with the quality of life in the school setting and outside the home residential setting and in the work setting. I do want to stress that Prader-Willi syndrome is not an eating disorder. Eating disorders are psychological, psychiatric in nature, and they're quite amenable to intervention, psychological intervention, psychiatric, psychotropic medication interventions. But Prader-Willi syndrome is a genetically based medical disorder, and there is no known medication or intervention that treats the PWS hyperphagia food drive. Doesn't exist. We're hoping that there will be an FDA intervention, medical treatment, medical intervention that will give us some kind of a treatment. But right now we don't have it. People with Prader-Willi syndrome cannot learn to control their genetically driven food drive, right? They may be able to, like if I told you, hold your breath because there's poisonous gas going to be filtered into your room, right? And you can hold your breath for a period of time. Just like somebody with Prader-Willi syndrome may be able to manage not taking that food for a period of time. But eventually your central nervous system function, your brain is going to gasp for air, no matter how much you know, if I take in that poisonous air, I will die. Same as for somebody with Prader-Willi syndrome. We've had people who said, I knew if I drank that, I would die, and I couldn't stop myself. It's the same principle. Eventually, their central nervous system, their brain overtakes them, and they will eat despite knowing it could kill them. No one known to be diagnosed with Prader-Willi syndrome can successfully live independently. No one known to be diagnosed has been able to live successfully independently. Those individuals who have tried have either become morbidly obese over a period of time and had to return to some supported living setting, or they have died. So until there is some kind of medical intervention, at least to treat the hyperphagia symptom, and this is certainly not the most serious symptom, actually, could be the most life-limiting, but there are plenty of other serious symptoms of Prader-Willi syndrome. Until such time, though, as hyperphagia is able to be managed, individuals diagnosed with PWS will need to live in the family home or some PWS designated residential setting. So the current state-of-the-art protocol for managing the Prader-Willi syndrome hyperphagia symptom throughout the world is 24/7 supervision every single day of the week, every single day of their lives. Let me turn my the print and we know we've got to have supervision 24/7, and we've got to adhere to what's called the principles of food security. And that, in a basic sense, is that access to food must be restricted in the home, in the community, and in all environments within which this individual navigates through their day. So there are a few medical factors that also complicate hyperphagia. There's a sporadic or an absent vomit reflex. So if the individual ingests poisonous food, rotten food, we may not be seeing vomiting. We're certainly not going to try to induce vomiting with some kind of emetic, because that'll induce more poison. If we're seeing vomiting, it could signal a life-threatening illness. Gastroparesis is a slow emptying stomach. We're going to be never, ever treating it with Pepto-Bismol or giving an upset tummy any treatment with Pepto-Bismol, since that slows down stomach emptying even more. We use a little bit of a change in the diet. We have also a slow emptying bowel. So we've got major constipation as a chronic symptom of Prader-Willi syndrome. Chronic constipation can cause diarrhea, but we never want to give Imodium when there's diarrhea, because that also slows down bowel emptying. And again, just as slowed stomach can cause death, so can slowed emptying bowel. Again, we manage this symptom with a different kind of a diet. Other complicating factors of hyperphagia is that there's a little a flap of tissue in the throat that doesn't close properly. So we have higher incidence of aspiration, of choking, pneumonia, and other lung-related incidents in Prader-Willi syndrome. And because the liver metabolizes at almost half the normal rate, we have major issues with any type of medication, particularly psychotropic medications, and particularly when we're having any type of sedation when we're going into a hospital setting. We've got to start all meds at low doses and increase only slowly. So whenever there's any inpatient or even outpatient surgeries, we've got to be informed and inform our physicians that this individual has Prader-Willi syndrome and the specific physiological issues that go along with this disorder. Scoliosis, curvature of the S curvature of the spine, and kyphosis, humpback, also in their severity can interfere with organ functioning. Scoliosis can occur in infancy, even beginning prior to birth, and scoliosis can continue even very differently than the general population, or even start very differently than the general population, where we can start a scoliosis cove long after the growth plates have closed. So again, the treatment from this specialist, orthopedic, must be informed about Prader-Willi syndrome. There are a host of additional physiological symptoms of Prader-Willi syndrome. I've listed them here for you. I'm not going to go over them, but they are all impacting your client, patient, student, etc., who has Prader-Willi syndrome. And again, most people will have most of these symptoms, but they may have them to different degrees. This is a spectrum disorder where even people with the same subtype of Prader-Willi syndrome will have different degrees or severity of symptoms from the same subtype. nobody knows why. Each person that you deal with who has Prader-Willi syndrome will need to be seen or has been seen by a multidisciplinary treatment team, from the geneticist all the way through urologists, GIs, dentists, ophthalmologists, psychiatrists, endocrinologists, neurologists. I mean, here's the gamut here. I personally, my son has Prader-Willi syndrome. I got involved with this syndrome 25 years ago when he was born, 26. And we've used every single one of these specialists and continue to see most of them. There is a document that's called the Prader-Willi Syndrome Medical Alerts that talk about specific physiological symptoms that are extremely different in individuals with PWS. First of all, there's a very, very high pain threshold for many people, and there can be serious illness or infection with no elevated temperature, no fever. So when we go to an ER and we are saying, hey, I think this person is seriously ill, first thing they're going to do is take their temp. Nope, no temperature, no fever, no fever. Go back to the end of the line. Or what's your pain? It's kind of a happy face because they're not good at recognizing pain. So it's important to provide good physiological symptoms to your ER specialists and any physicians you deal with, because they're not going to know. This syndrome is so rare. All right, we've kind of very quickly did a nice thumbnail, hopefully, of the physiology of Prader-Willi syndrome. Now let's look quickly at the neurocognitive symptoms of PWS. So global developmental delay impact every one of our kids. You will see under the age of 5, everybody meets that global developmental delay criteria. And every one of our kids now, because the DSM requires IQ score and adaptive functioning skills scores, will now meet intellectual disability diagnosis. Generally, the IQ range, just a straight out IQ, ranges from mild to severe, with only 5% of people having an IQ score of 85 or above. But again, they're going to have adaptive skill function deficits, or 5%, on the other side of that bell curve, having profound intellectual disability. It's important, too, that you know that growth hormone treatment that begins before the age of 12 months will actually improve IQ scores. So that's important for you to know, too. A couple of things about intellect. They higher cognitive abilities and verbal skills don't mean that the individual has any ability whatsoever to override or, think above their hyperphagia symptom. Doesn't work that way. Likewise, people with very, very impaired intellectual functioning can be brilliant about thinking of multi-step ways to plan and get food. But these don't seem to generalize to other areas of life, these abilities. It's almost like a savant skill for people with Prader-Willi syndrome. And even the most honest person with Prader-Willi syndrome may lie, cheat, or steal when it comes to food. This is simply a symptom of the syndrome. Anxiousness is that excessive worry, fear, feeling out of control. It is experienced to some degree by all individuals with Prader-Willi syndrome. Most of us in this field say, PWS is an anxiety-based disorder. It is not treatable with anxiety-based focused medications, though, unfortunately. So there's a very high need for routine, sameness, predictability. Attention deficit is that a need to stay on task, understand directions. Hyper-focused on things is a symptom of attention deficit. Difficulty with transitions. Most people with the syndrome have attention deficit issues. Concrete thinking is a symptom of Prader-Willi syndrome, especially the passage of time. 5 minutes can feel like 5 years. 5 years like 5 minutes ago. Egocentrism impacts almost every one of our people with the syndrome. They have that lack of theory of mind, great difficulty seeing things from anybody else's perspective other than their own. Executive function skills deficits reign in Prader-Willi syndrome. So we've got problems with planning, organizing, prioritizing, transitioning, problem solving, etc. Frustration intolerance, huge symptom for most people with Prader-Willi syndrome, leads to disappointment and big time behavioral issues. Impulse control disorder, elopement, very common, even when they're not eloping and running away in order to get food. Wandering away, very common with our, especially the younger individuals. People with Prader-Willi syndrome generally want what they want when they want it, which is right now. Again, I mentioned earlier, we had people, who are upset, kind of upset about something, jumping out of a moving vehicle. That was on a freeway. That individual passed. So we've got major impulse control issues. Inflexibility, rigidity. People have great difficulty with changes in routines and schedules, and inability to kind of go with the flow. External motivation is required for almost everybody with the syndrome. We don't have people who are able to schedule their own days, because if left to their own devices, they're just going to kind of sit around or sleep all day long. The need to be right or good in other people's eyes, the need to be right to themselves, huge in individuals with Prader-Willi syndrome, and it can lead to major power struggles, arguments, meltdowns. Obsessive compulsive tendencies, perseveration, rumination, collecting, hoarding, picking, sorting, pulling, and tearing, all under the obsessive compulsive tendencies. It's not obsessive compulsive disorder. In order to be a disorder, it has to bother the person who has these symptoms. People with Prader-Willi syndrome are not bothered at all by their perseverative, picking, etc. behavior. Everybody else around them is bothered by it, but not the person. So it isn't a disorder, but it sure is bothersome. Oppositional tendons reign again in Prader-Willi syndrome. The brain's automatic reaction is often to respond with no. So this looks like oppositional, stubborn, defiant, and argumentative behavior, because it is. Self-monitoring deficits. People with Prader-Willi syndrome lack the ability to really accurately evaluate their own performance and their own abilities. So people often have this concept called delusional grandiosity. So they may tell you, I'm a great swimmer, when in fact they could sink to the bottom of the pool like a stone, unless you're there knowing what their actual swim capacity is. So let's take a quick look now at the behavioral phenotype and manifestations of Prader-Willi syndrome. So, I like this diagram because what it says is, we might see some of the behavior up here. It's just the tip of the iceberg for what individuals are thinking or feeling down below. I just got off of an observation in a classroom setting where we could, I could see something upset the individual with Prader-Willi syndrome. We could figure it out. I couldn't see the brewing of it happening, but nobody else, it didn't look like anybody else is seeing what's really going on. The person is thinking, this isn't okay, this isn't fair, this is not so good. So all of this stuff underneath is brewing, and then we're going to see an eruption. I had to get off so I could be onto this webinar, but there's something brewing at the school site. So there are a multitude of physiological symptoms that cause maladaptive behaviors in persons with Prader-Willi syndrome. And there are also a multitude of neurocognitive symptoms that cause maladaptive behaviors in individuals with Prader-Willi syndrome. This is why maladaptive behaviors, in addition to hyperphagia, are the other hallmark symptom of Prader-Willi syndrome. So it's often actually even the most challenging. I say sometimes, we can manage hyperphagia. It's much easier sometimes to manage hyperphagia than it is to manage all the rest of the behavioral symptoms of the syndrome. So real quick, behavioral manifestations in infants and the young child with Prader-Willi syndrome. In infancy, it looks like they're not awakening to feed. They have little interest in feeding. They'll sleep throughout the whole day and night if they're not awakened in order to feed, or they're not being stimulated. Infants rarely cry and often exhibit very, very weak cries if they do. Infants will die if they're not awakened to feed. Most infants are kind of non-responsive. They don't have a lot of facial muscles that work properly, so they have not a lot of feedback facially to give to parents. It can be quite challenging. This is typically a very, very stressful stage for parents who, as you can imagine, have just had their baby. Usually there's no symptoms that are recognized. There are symptoms in prenatal, perinatal, but nobody recognizes them yet. So babies are born and parents had no idea that there was going to be potentially something going on. In the young children, age 1, 2, 3 years are typically pretty happy. Under the age of 3, they're pretty compliant. They're pretty cooperative. They're just lovely little people. There continues to be a very stressful time for parents, though, because there's lots and lots of medical appointments, therapy appointments, learning what symptoms are coming up, how to recognize them, how to manage it if they have the diagnosis. Maladaptive behaviors typically begin to occur when hyperphagia occurs sometime after age of 2. 2, 3, 4, 5, 6, 7. We start to see hyperphagia ramping up, and then maladaptive behaviors, ramping up as well. And those behaviors, again, look like the oppositional, argumentative, rigid, obsessive compulsive, repetitive, self-abusive, skin picking, temper tantrums, crying, verbal aggression, yelling, screaming, obscenities, physical aggression, hitting, kicking, punching, biting, pulling hair, throwing objects, property destruction, theft, especially food-related theft, lying to avoid blame. I can't be wrong, so no, I didn't do that naughty thing. Confabulation, including confabulation is making up stories out of whole cloth for apparently no particular reason at all. Where it gets pretty serious is when we make false allegations of abuse, which is not uncommon, unfortunately, with people with Prader-Willi syndrome. Wandering away, especially at the younger ages, and elopement. All of these very, very common behavioral manifestations in the child throughout the rest of the life. This is always a stressful time for parents. Behavioral symptoms are similar to and often far more severe than those seen in individuals diagnosed with autism. So what maladaptive behaviors, what can they look like? They can look like kicking walls. They can look like breaking shower glass or, anything glass. They can look like swatting the pictures in the hallway so that they fall off the wall and break over the floor. They can look like destroyed rooms. So this is a picture of a room that was not like this before this young boy actually had a bad behavior. Now you see this table right in the middle of the room. That's a solid granite, hardwood with wrought iron decoration. Very, very, very heavy table. So it's interesting in people with Prader-Willi syndrome, and we don't really understand the mechanism yet, that we've got very weak muscle tone almost all the time. But when we are upset, we have normalized muscle and we're very, very strong. So maladaptive behaviors in people with the syndrome can be quite, quite tough. Prader-Willi California Foundation teaches courses and provides training either online or if necessary in person to help parents, schools, residential providers, and others manage the physiological and the neurocognitive symptoms of Prader-Willi syndrome. And we are also authorized to provide CEUs up to 12 per year, which is what you need, to adult residential providers. So if you ever need CEUs, you ARFs, you let us know and we'll work with you to provide some good training. Just a couple of notes here. Behavior modification is not an appropriate intervention or a goal for people with Prader-Willi syndrome. Behavior management is our key phrase. We don't change the behavior with people with Prader-Willi syndrome. We manage it, and then because when we take away those supports, behavior resumes. Maladaptive behavior resumes. Also, ABA therapy that does not incorporate PWS physiological and neurocognitive symptoms and incorporate known PWS interventions and strategies is not indicated. It's contraindicated. It will backfire on you. So there's put together a very brief guide to symptom management by age. Okay, because age is not just a number. There are some symptoms that are kind of age relevant. So briefly, symptom management of the newborn through age 2 includes, of course, feeding support, growth hormone medication, now state of the art around the world if they can get it anywhere else in the world. Coenzyme Q10 is a supplement, sleep study to assess for central sleep apnea, obstructive sleep apnea, oral motor therapy for the young infant to improve the mouth muscles, and then occupational therapy and physical therapy as the infant ages. Orthopedic abnormalities require intervention and treatment from an orthopedic specialist, including foot pronation. We may need orthotics. We may need we will definitely need to assess for scoliosis starting at a very, very young age. And then diet management that's specifically informed by Prader-Willi syndrome and the PWS nutritional phases is necessary. And then, even at the birth and through age 2, we really want our families to start focusing on getting their family trust created, special needs trust created in that CalAble account if necessary. Symptom management from about age 2 through late childhood includes creating Prader-Willi syndrome specific environmental basics, food security, which includes restricting access to unauthorized food, diet management, which requires a very restricted calorie and carb specialized diet, growth hormone medication throughout childhood, supplements like coenzyme Q10, NAC, again, PWS informed behavior management strategies, OT/PT, speech and language, social skills therapy, absolutely important. And then monitoring for all abnormalities, including optic abnormalities, gastroparesis, the slow emptying stomach, slow emptying bowel. Absolutely critical that we get daily physical activity into the routine of the child at a very early age. Social media, absolutely critical. Our kids cannot, and our older adults particularly, cannot manage social media safely at all. Special education services, and again, that special needs trust, family trust, CalAble account reminders. Symptom management from adolescence through adulthood include continued food security, diet management, environmental basics, all the OT/PT, social skills things, sex hormone replacement therapy, including sex education, dating, sexuality, and social media safety, money management support. Money equals food to the person with Prader-Willi syndrome. So we really need to be watchful that we're not giving money to the individual with Prader-Willi syndrome. And then monitor for any emerging abnormalities, etc. Later adolescence and adulthood, supports with supervisory in the school setting and adult transition programs. So hard for our people because so many adult transition programs are food centric. Let's go to the mall and practice math skills. So we're going to need to kind of put the I in the IEP for our adult transition programs. Employment needs a job coach, day program, we need supervision for the individual with Prader-Willi syndrome, and certainly restricting their access to food, which is quite challenging in an open environment where we're working in the community setting. Transportation supports, we got to make sure we can have the greatest residential facility in the world, but we can have the greatest day program in the world, but if we don't have transportation back and forth that's appropriate for the individual with Prader-Willi syndrome, we're going to be in big trouble. Special needs trust, family trust, etc. Really important, especially as parents are aging, and the individual is going to need support throughout the lifetime. We need to encourage parents to get these things in place before we die. Social Security benefits, SSI, conservatorship at age 18, residential needs also from age 18, including the pros and cons of a family home versus an outside home support, group homes, ARFs versus supported living supports. There are pros and cons depending upon the family and the individual with Prader-Willi syndrome for both of these. So let's take a quick look at the role of direct support staff and other professionals, right? If you're a regional center professional, as soon as you receive a referral, either from the NICU or from the family, right, that the person coming before you has Prader-Willi syndrome, please provide Prader-Willi California Foundation's contact information so that we can then provide the family and the professionals working with that family with in-depth education and support. Right? We've worked directly with NICU docs to get that infant, that neonate with growth hormone treatment right away so we can avoid that G-tube surgery, right? So we can share feeding tips with the parents and with the nursing staff in the NICU. We want to be able to provide in-person or online support to families and behavior training. The earlier we start, the better, to families, school personnel, residential providers, vocational providers, community employers, recreational providers, babysitters, respite providers, right? We want to be able to provide that support as requested by family. Help the family obtain Lanterman Act eligibility when they turn age 3, right? So whether you're going to be finding them eligible under intellectual disability, or if they have autism as well, or if they have epilepsy as well. A lot of our people have epilepsy also. And then, if not able to find autism or epilepsy, and we still would say ID, but fifth category would be the way to go. And then do ensure that Prader-Willi syndrome diagnosis is correctly coded on the CEDAR. It fell off the ICD for a number of years, and so Prader-Willi syndrome was coded differently as something else. So we want to make sure that everybody who's got Prader-Willi syndrome got a correct diagnosis on their CEDAR. And then we want to make sure that the IFSP, IPP reflects all the deficits and the needs of the consumer. And then ensure that those needs are reflected in the evaluation element so that we're really coding the severity of the symptoms and how much work parents are doing to make sure their kid is safe. Begin early start or Lanterman supports, whatever the age of the individual, as soon as you can, as quickly as possible. Early intervention, we know, is particularly critical in Prader-Willi syndrome to reduce or avoid symptoms at a later age. And that, this can be an expensive syndrome to manage, especially if we're not doing some good early intervention and helping to manage behaviors and diet and weight, etc. And then appropriate manage of symptoms. Again, it just saves money for the state in the long run. Know regional center professionals that the critical supports that your consumer needs by the age of that consumer, right? We kind of went through those in infancy, childhood, and adulthood. And then again, use Prader-Willi California Foundation as a resource for yourself. Let us help you identify the PWS supports that may be necessary, or at least you can check them out if they're necessary for your consumer and the family, and then provide PWS specific information and training to your vendors who are working to support somebody with the syndrome. So for you residential service providers out there, remember that no one known to be diagnosed with PWS can successfully live independently. And again, those who've tried have either become morbidly obese and had to return to a home setting or some setting, or they've died. So for the health and safety of your consumer with Prader-Willi syndrome, the residential support must be a PWS trained facility and or SLS, and must have waivers or agreements in place to legally restrict that consumer's, that resident's access to unauthorized food. Know that people with Prader-Willi syndrome are not able to live successfully in mixed non-PWS or PWS, both people are living in the same group home, unless the people who don't have Prader-Willi syndrome have other restricted diet, the same restricted diet needs. There is a weight management home up north, and people there don't have Prader-Willi syndrome, but they have weight management needs. So the home serves both well, I believe. So get that Prader-Willi syndrome management training, behavior management training from PWCF. It's free. As a matter of fact, we're going to be offering another one next Tuesday. It's free of charge. Unless you need CEUs, then we charge nominally for that. Remember, it's not all about food. There are a host of neurocognitive symptoms, remember, that cause serious maladaptive behaviors. So people with Prader-Willi syndrome have to be kept busy. We have to manage their food, but we have to keep them busy in other ways too, to reduce maladaptive behaviors. For you vocational, day program, volunteer service, recreational service providers out there, nobody known to be diagnosed with PWS can successfully work independently. So we need to have some supervisory support, job coach for the health and safety of the people you're supporting. People with the syndrome do require specialized supports throughout the day, if at all, again, at least in regard to money, in regard to food, but certainly in regard to access to money, access to other people's money in their wallets or purses. It's really important. Get PWS behavior management training from PWCF. Again, we're going to provide it free of charge because we know how helpful it is. And I want to end, at least this portion, with just kind of letting you know, what do PWS parents feel? Well, they feel anxious at every stage of the game. They're going to feel, from the moment they get a diagnosis, afraid, overwhelmed, in the beginning, naively hopeful, trusting of what physicians tell us. And then we find out, well, that wasn't quite true. They're not informed about Prader-Willi syndrome. Submissive. Well, I believe what the doctor tells me. In denial. I'm not going to believe what the doctor tells me. Confused, helpless, irritated, angry, depressed, distrustful, fed up, and most of all, stressed. So if you're working with a parent who appears irritated, it may not be necessarily with you, but the situation and the culmination of chronic stressors, or the fact that the parent really does know how Prader-Willi syndrome is impacting their child or adult and what you could do that could help them. So please have patience, learn more about the needs of your consumer, resident, patient, and work together maybe to even think outside the box. So on behalf of all of the people that you're serving, thank you for learning as much about Prader-Willi syndrome as you can, so that you can best support the individuals with PWS who are in your care. So now I'm going to give you, it's already in your packet, but my contact information is here. Prader-Willi California Foundation's contact is here. Again, we live for training. We live to kind of brainstorm, well, but we tried that and that didn't work. What else could we try? So with the time that we have remaining, I'm going to stop the share and open it up for any questions. And I know right about now, people's heads are blowing up. So I apologize for so much information so fast.
Thank you. And feel free to use the chat box too. I have it open. If anyone wants to type anything in, you can also look at that and read it out loud. Okay, one of the questions is, what is the difference between PWS and PWLS?
So PWLS is Prader-Willi-like syndrome. PWS is Prader-Willi syndrome. Prader-Willi-like syndrome was created because in the ICD-10 in the medical field, because there are people who have every clinical symptom of Prader-Willi syndrome, but test negative genetically. So we know that our testing for Prader-Willi syndrome isn't sensitive enough yet. And so instead of, saying, well, bye-bye, we can't help you, there's a code that's given to Prader-Willi-like, that all symptoms are just like Prader-Willi syndrome. We manage everything the same as Prader-Willi syndrome, genetically tested. And somebody I saw in the chat, what about race? Is there any differences in race? No, there's no race that is spared by having somebody with Prader-Willi syndrome. Nope, affects all races, both male and female throughout the world, the same.
Thank you. We have another question. How do you safely secure food?
So that's a great question. In the home, so we have to have routine. That's a whole nother training, right? That's all. We could spend 2 more hours on just food security. But basically, you schedule food when it's going to be served. At the same time, you create those routines every single day. And then you restrict access to getting extra food by putting locks in the home, on the refrigerator and food pantry, and not keeping food out. In the residential setting, you do the same thing. You restrict access to food with locks on the food pantry, refrigerator. In the school setting, you collect lunch boxes. You don't allow students to get into lunch boxes before whatever time is scheduled for food.
Thank you.
But that securing food in a community setting is really, really hard because say we go to the mall and let's say we're not even eating food at the mall, but most malls are set up now so you have to pass through a food court. Well, we have some individuals who cannot tolerate that there's access to food in that area, so they'll bolt, they'll run up, they'll take food off somebody's plate, they'll eat it, or they'll steal food in a store, they'll pocket it, put, candy, whatnot, chips. It gets to be quite challenging in the community. At home, we can restrict access to food, most of us, all day long. It's easy at home. It's getting out into the community where food is ubiquitous that gets really challenging.
I did have one question. I know you listed the different types of specialists and providers that are individuals with PWS should be connected to. Are there any challenges, or because with some of the symptoms can develop other chronic health conditions, with the overeating and think of cardiac, diabetes and all of that, the specialty. Any tips or tricks around that, working with those types of specialists with our individuals, challenges that some of our individuals may have faced in getting connected to the appropriate services? I know that's more of the medical side and working with a primary care doctor, but
Yeah, but that's a great question because
Yeah.
many primary care doctors are clueless.
Yeah,
So we do have, so most of the time, the biggest healthcare concern we have is obesity. And then, I mean, I showed the picture of the young little 5-year-old who's already morbidly obese, right? So morbid obesity, diabetes type 2 are very, very common in people with Prader-Willi syndrome when we're either not having restricted access to food or extra food, or the diet that we're consuming is not appropriate for somebody with Prader-Willi syndrome. So in California, we're pretty lucky that we have pockets of children's hospitals that have Prader-Willi syndrome. I want to say units, right? So at Children's Hospital in Rades down here south, we have a Prader-Willi syndrome clinic. Children's Hospital LA, we don't have a clinic per se, but we have some specialists there. At Stanford, we have a Prader-Willi syndrome clinic. So we do have, and PWCF maintains a list of endocrinologists, and that's your primary care for persons with Prader-Willi syndrome is the endocrinologist. We have a list of endocrinologists. Most endocrine specialists really only want to treat children. And when we have a child who's aged out of, at 21, 22, and children's hospitals or the ped providers say, you're aging out now, it becomes very challenging to find an endocrinologist who will treat adults. So that's where we say, find an adult endocrinologist that you feel comfortable with, and then we'll provide you with some information that you can then provide to that endo specialist that's specific to Prader-Willi syndrome.
Thank you. That's great. That's great information. We can always refer individuals to the website too. Because the unfortunate thing of being so rural up north is for kiddos, the closest tertiary hospitals are in the Sacramento area, which is several hours away from some of our folks up north. So,
and we don't have a PWS clinic per se in the Sacramento area.
No, we have the different specialties. It's just not the PWS like you mentioned. So, yeah. But it's good to know that there are other in Stanford and down south. If anyone needed that additional support or would benefit from that, so it's good to know.
Yep.
Yeah. Thank you. Any other questions from the folks still on? I know Beth wrote, great training. She learned a lot. I'm sure we all did. It was always great to listen to you speak and address all these different areas of concerns. And I'm sure everyone got something out of the training. So thank you so much for joining us today. Thank you so much for giving me the opportunity. I really appreciate that opportunity on behalf of PWCF. Let us know when we can be helpful. Great. Thank you so much. Thank you. Thank you. Bye, everyone. Thank you. I'll just stay on just till the end. Sometimes there's shy people who will ask a question at the end. Yes. I haven't ended the meeting yet. That's fine. Well, we had a great turnout. It doesn't look like it on the people that sign in, because sometimes we have groups that one person logs in and there's like a group of 10 of them watching it together. So, oh, great. Great. Yeah, I think people were really excited to join in today. So thank you again. Yeah, absolutely. I hope the information was what you were looking for. Yes. Good. Absolutely. Yes. Thank you. I know it's so much to cover in an hour time, but it's a good summary. Yeah. Yeah. Good. Good. It is. It's a lot of time to cover. I mean, a lot of things to cover because this syndrome is so wide and so diametrically opposite from early symptoms to later symptoms. It's like, holy gee. Yeah. Yeah. A lot. a lot that I'm sure parents have to learn, and as that child grows and understand.
Overwhelming.
Yes.
Yeah. Overwhelming. Yeah. Yeah. So it's great that the individuals here now have some hopefully broader idea of Prader-Willi syndrome, and then where to go to share that information with their patient or their consumer that
Yeah.
that they're working with. Yeah.
Yes, absolutely. Okay. Well, I don't see any other comments in the chat box.
Okay.
No. Mhm.
Got a lot of hanger-oners.
Yeah. Thank you. Well, again, thank you so much. I think there's a few that just kind of hung out, but
Yeah.
I'm not sure if they're still really with us.
They may
Thank
not
you.
be.
Thank
Thank
you.
you.
Yes. Have a good evening.
You too. Bye-bye.